Good day to you. My name is Ajamah Samuel. I am the nursing team supervisor, Sokoto Project, NOMA Hospital. I'm also the project leader of the NOMA Discharge Toolkit. I will be presenting on the NOMA Discharge Toolkit, a person-centered approach to improve continuity of care. NOMA disease is a rapidly progressive and often fatal necrotizing bacterial disease, which continues to be neglected. It has a high mortality rate if not treated, and a high level of readmission or loss to follow-up on discharge. The NOMA Discharge Toolkit is a project initiated and led by the NOMA project team and ably supported by the Sampling Nursery Fund, MSF UK. Through community-based exploratory assessments, it was found that caregivers do not have enough resources, knowledge, and overall capacity to continue with the necessary treatment and care after discharge. So the NOMA Discharge Toolkit is the solution to this identified problem. The strength of this Discharge Toolkit and of this study is the person-centered process. The study actually started with exploratory phase, with patient journey mapping, stakeholder analysis, interviews, workshops, group sections. Through this approach, we were able to identify the main problem of the NOMA patients, which is what happens after discharge. And also, through this process, we are also able to identify the solution to this problem. So, from this approach, we are able to identify items to be put into the kit and how to integrate them to continuity of care process. The NOMA Discharge Toolkit has 4 components. We have the booklet, which is basically contains stories to transfer knowledge to the patient. One of the things we found out during this study is that the patient caregiver in the hospital is not actually most of the time are not the primary caregivers at home. So a lot of knowledge is disseminated to these patients. The knowledge is transferred to these patients and their caregivers while in the hospital. But by the time they are discharged home, this knowledge will be lost because the patient will now be handed over to the primary caregiver, who in most cases are the parents of the child at home. So the booklet, which is written in the local language, contains stories and information that will help them to take care of the child while at home. The second component of this toolkit is the nutrition component, which basically contains items like patch pap and plumpy nuts. The third component of the toolkit is the non-food items, which are items basically for hygiene promotion. Then we have the medication and treatment components, which also have items for materials for storage and transportation of the items in the discharge toolkit. One of the things we're able to do during this process throughout the study is inclusion and integration. All hospital staff were involved, various departments, focal points in the communities were involved, and the caregivers of these patients also play a greater role in coming up with the discharge toolkit. So far, over 20 to 30 patients have benefited from this discharge toolkit. And readmission has, readmission, unlike before, from beneficiaries of this discharge toolkit has not been recorded. Initial feedback from patients and caregivers, from staff in the hospital, from focal points in the community has been very positive and impressive. We have a patient who testified that before she knows about this discharge toolkit, when the time of discharge was coming here, she was so afraid of going back to the home situation, which in the first place lead to the NOMA disease. But on getting to know when this discharge toolkit was introduced to them, she was so happy that on discharge, she will go home with items that will take care of the situation that can lead to relapse of the patient. We also have feedback from staff and caregivers. From staff, for example, from the nutrition unit, when patients are discharged, they are always assessed. There are parameters we use to assess them before patients are discharged because there's a target for discharge. For example, we have the MOAC, we have the weight. So when patients are discharged, these parameters are checked. And when they come for follow-up, again, these parameters are checked. From what we have seen so far, all the patients who have benefited from these toolkits do come back with good measurements, assessments, positive assessment when these parameters are checked. We've also monitored readmissions and follow-ups. So far, I think the story is positive. Lesson learned and next steps. So far, we have learned that the person-centered approaches take time in studies. We also learned that feedback is very important for understanding impact of studies like this that involve patients, caregivers, and the communities. So far, the feedback we are getting, like I said, are very positive. From feedback, for example, we have been able to add 1 month replenishment of consumables. In other words, based on the feedback we get from the caregivers and the staff and the community, we have made it now that for a patient who who benefited from this toolkit, when they come back, they get additional 1 month replenishment of consumable. This is outcome of feedback after analyzing the feedback from these caregivers and stakeholders. So our next step is to assess data, collation of data, assessing data, and adapting and exploring how to integrate the NOMA discharge toolkit into Sokoto NOMA project. Thank you.